Well, hello, everybody. It is Friday, June 18th. It is the day before Juneteenth celebration, and what it is a symbol of freedom in America that we'll be celebrating. But you cannot celebrate Juneteenth without actually talking about things that bring us freedom or remind us of freedom or things that will actually further give us our freedoms. So we're going to be talking about price transparency. I have two of my favorite people coming on as guests. I will introduce them later. Right now, get to the intro of the podcast, and I will be right back to start the show. America's medical system needs healing. Free to Care has real solutions. Our mission is to magnify the voices of the patient and physician. We want to take medicine back to its original purpose. Join host Dr. Nikki Johnson for Free to Care, the podcast, for conversations on lowering prices, making prices transparent, personalizing medical care, taking bureaucrats out of the system to bring you more choices for your healthcare dollar. We know that healthcare is personal, not partisan. Join us live Fridays at 8 p.m. Eastern for Free to Care, the podcast. Okay, we are back. I'm going to pull up this video that is.
All I heard is, I need the surgery. It's pretty much life and death. But he
Yep.
never said.
I'm going to be bringing up this video that's from price transparency. It is going to come from one of the Free to Care members, patient right advocate, who wants you to know that you have a right to hear and know what your prices cost for healthcare, and you will be astounded to know how much they actually cost. One second here. Let me see if I can pull this up. I am having trouble today. See if it will let me go to. To share my screen. All right.
All I heard is, I need the surgery. It's pretty much life and death. But he never said $101,000. And he never said, oh, by the way, I don't accept your health care.
You don't know any prices?
Until weeks later when they send you the bill.
As if it's not bad enough to think your child might die, but to worry about how you're going to pay for it.
Am I taking care of my family, or am I going to go pay a copay so I can go to therapy? Well, I pick my family. How many people have avoided healthcare because their first thought is, what's it going to cost?
When you don't have to justify the price that you're spending because it's a secret to everybody, you can charge whatever you want. And without transparency, there's always going to be that variability.
He hears the debt collectors calling the house. He knows his dad's sick. I'd like for this to be taken care of so that my son doesn't have to deal with it.
We probably wouldn't have any customers if they didn't know what they were paying until they got to the cash register.
We decided we should post all of our prices online. We have changed our pricing on our website 4 times, and in each instance have lowered the prices.
When I cut out all of the bureaucracy, I'm going to pay hundreds, if not thousands of dollars less than I would have otherwise going through this insurance company, which denied my care anyway.
How do my prices compare, say, to a not-for-profit hospital here in this area? And invariably, the ratio is 6 or 8 to 1. We had a patient from Georgia that was quoted $40,000 for a procedure on our website listed at $3,600. The patient used our price to leverage a better deal. They actually matched our price in Georgia.
The closest I got 2 ballparks. One was 15 to 25,000. and the other one was 30 to 45,000. I go to Texas Free Market Surgery. Tympanoplasty was listed at $5,000 on their website, and I was blown away. This is the solution for driving down healthcare costs for everybody. It's working for my family.
Patients thinking like consumers is what will actually transform the healthcare system, will drive down costs, and will actually improve health outcomes for everybody.
We've taken the outside of healthcare and said, you know what, we're going to blow this up and make it transparent, and our clients have achieved the savings.
We're cutting out the insurance carriers, we're cutting out the networks, and we're going directly to the hospitals and the providers and getting the best price possible.
To be able to know that I was able to have this procedure and it not cost me a penny and save $5,000 was a huge relief to me.
Think of a knee replacement. Our average cost is $20,000. Somebody comes through us, they don't pay their out-of-pocket. Maybe they have a $3,000, $5,000, $6,000 deductible or higher. And it's 10% of the charge, they get a $2,000 taxable bonus. Put money back in an employee's pocket, that's a mortgage payment, that's a utility bill, that's food on the table, that's real.
Actually, I went to apply for Medicare, and the Medicare guy that brokered it told me that my plan was better than what he could offer me.
Direct primary care, what it does through its transparency and the time we can spend with the patients, once we remove the third parties from the exam room, we give affordability through complete 100% transparency.
We lowered our cost by 3x, at the same time lowering the team members' cost by over $3,000.
I can look at 4 procedures that save this company $100,000.
Almost a 50% reduction in the cost per employee per month. So I'm getting better results from the medical side, but I'm also from a cost containment side, significantly better.
So it's a win-win. The employers are saving money, the employees are getting actually better benefits.
I think we'll have a healthier population because they will go to that doctor rather than put it off because of cost.
Let's get this down into a world of reality instead of some make-believe number that has been inflated and conflated over the years to the point that we all think it's true.
Over the last 10 months, we've saved our taxpayers just over $500,000, which is money that we don't have to go out for a tax increase for.
The way that you would think in an ideal world, this is how this should work. That's what's happening.
All right. So right now, everybody needs to go to patientrightsadvocate.org. Go in and look at a call to action for you to go and sign and let HHS know that you want the hospitals to do what they're supposed to be doing. And the reason why I led off with this topic is because this is very important right now. HHS is President Biden's HHS is going to try and agree with the hospitals that don't want to give you prices, a price transparency, because they feel it is too much of a burden on them. So please go and make your voices heard today. And this is going to lead me into talking about some of the things that are not transparent in healthcare that I want my friends, Dr. Caren Gallaher, of Tennessee. She is my Jewish sister from another mother. Both of us shared that our very first concert together was the DeBarge family, DeBarge concert. And so we have that in mind, but she is one of my partners in crime in all of this. And then the other person is Dr. Marion, who is the great organizer and coordinator. I call her my personal LinkedIn. She is also one of the Med Vendors and a sister friend, a dear friend of mine, who makes a lot of this possible. Both of these people are leaders in Free to Care as well. We're going to be talking about the major players that are causing problems with you getting access to affordable care, actually getting access to a physician-led care, and the things that are keeping your prices high. So welcome to the studio, my besties, Dr. Marion Moss in her spring and summer robe. Are you? Yes.
I am. This is actually a gift from another Free to Care member group, Marlene Smith from the Physician Outlook. So she came today and she said, I have an early birthday present. You need a summer robe instead of that duck plush robe that I.
Very nice.
Hi. Hello.
Happy
friends.
How are you? How's Tennessee? Are you in Tennessee right now, or
in South Carolina right
okay.
now?
Okay.
I'm actually in a shipping container.
I'm
staying
okay.
in a great Airbnb that's a shipping container. So voila.
All right. Well, let's get to it. Let us start. Just introduce both of yourselves, and tell. This is just a reminder. This audience is mostly people who are not in medicine. That's what we want. That's who we're trying to reach with our message. And I want you to just sort of let them know a little bit about you, what you do, why you think free to care is important, and then we'll just dive into our topics for today. So, Caren, Dr. Gallaher, will you go first?
I will. Thank you, Nikki, for hosting this podcast. It's been wonderful. I've loved the episodes that have preceded this one, and I'm really excited to be here with two of these wonderful women physicians that are such advocates for patients. And thank you both for shining the light and leading the way. It's a great journey, and I'm happy to be here with you. I am a retired surgeon. I'm officially 6 years out of practice. And during that time, I was found by Marion and Nikki, set my feet on the pathway to advocacy. It's kind of crazy to think that I spent decades, almost 3 decades practicing medicine, but really beyond advocating individually for my patients or as a medical director advocating for my program, working with legislators to get trauma funding or breast cancer funding. I didn't really have a good feel for what healthcare policy was about. And fortunately, silly Facebook, my children always tell me how silly I am to be on Facebook, but it has opened great doors and allowed us to come together. And Nikki and I helped to form a not-for-profit to help educate physicians and patients and legislators. And Marion has been such an ongoing river of information to get us all educated so that we can work together. And it's astounding. So for patients out there, the layers and layers of silencing information and creating an issue so that we feel like we can only be insured and we can only get medical care in one avenue. That all is going to hopefully be shattered today when you hear why things are the way they are and what we can do to change it so that we all can have affordable, good medical care that doesn't have to be expensive at all.
Right. You said it. All right, Marion. Dr. Moss, bring it.
Hey, welcome to my gazebo. Marion Mass. I'm a pediatrician. I've practiced here in Southeast Pennsylvania for over 20 years. My educational travels, Penn State, Duke Medical School, Northwestern, then back here to Pennsylvania. And, my husband and I started spitting out little kiddos. And then I was working nights and, pretty much barely sleeping. And then I was like being Rip Van Winkle. I woke up one day after the children were all potty trained. And I'm like, what the heck happened to medicine, right? And, this is awful. Like everyone's telling us, the physicians, what to do. The patients are paying more. They're frustrated. Everyone's paying more. They're getting less. And what happened? And so I just decided, money must be involved here, right? It always is. So I started looking into like costs, and it's really taken a long time But I think what I like to focus on is, for the patients out there, I think maybe we should each tell some of our personal stories as to what really made us passionate about this. But what I like to do is uncover the little hidden warts. There's no hidden gems. If anyone's hiding stuff, they're not gems, they're warts in the system. So we need to uncover the hidden warts in the system and expose to people who's making the money, because you all know you're paying more, you're getting less. Someone must be making out like a bandit. Don't you all suspect there's someone sneaky behind the curtain? Well, I think
Lots of sneakies.
Let's talk about the sneaky people.
Yeah. So, all right. So let's get started. Let's get to the nitty gritty. A lot of the people who watch the show, they want to ask me specifically, how can we cut costs? Last week, I talked to Dr. Kim Legg-Korba, one of our favorite direct primary care docs, who actually was featured in that video that I just showed from Patient Rights Advocate. And she talked about actual costs of the care of just seeing her patients and direct primary care. But what are the things that are making the prices so high for patients going to a hospital to have surgery, or medication prices that are so high? What do you think is the main reason for that, and then what can we do about it?
Can I start? I'll start with the simple and let Marion go on to really get into detail about this. Many people will find it very hard to believe that not any other industry in our society works on a system where cost, charge, and payment are totally disassociated. They're not related at all. So a physician can charge X dollars, but the actual cost is Y dollars and the payment is Z dollars. They're not related. And this opacity, the lack of transparency, is part of the huge problem here. As a medical director, when we're trying to figure out how can we do better care that's less expensive, do we really need to do this test? And you ask administration, well, how much does this test cost? Nobody can tell you what it costs. They can tell you what one insurance pays for it, or another insurance pays for it, or a patient who is paying out of their pocket pay for it. But what does it actually cost to produce and utilize the test and send it to the lab and get the results back? Can we do anything to make it less expensive? Those answers were evasive. Nobody could tell us that truth. And so it's very interesting when you start to dig into that and find out really what's the root cause there. And Marion knows those answers and writes about them quite a bit.
And and before I let Mary answer, I just want to emphasize that you guys, we go to med school and we go through our residency training. We don't learn this stuff. We don't know this. And so it took us, taking time to figure it out. Something sparked our interest in that, and whether it was feeding off of each other, social media, we wanted to figure it out. And so, like we just go along, we're doing our training, we're trying to take care of our patients, and then all of a sudden things are starting to happen around us. Like Marion said, while the kids were potty trained, and all of a sudden, whoa, what happened to healthcare? So Marion, you take it from here.
Okay, I guess I'll try. If I'm going down a rabbit hole too far,
that's okay. There is no such thing. This is a huge topic, so this is not going to be the only episode on this. But
sure. I mean, I think and I can't say I know everything, but what I've seen patterns of things. And like sometimes what I see is like when the information is missing, that's when I really dig down. So I guess I got basic at one point and just like looked at what were some really big cost drivers that everyone knows are cost drivers. And what you get to is you get to insurance, hospital, and drug pricing, right?
Right.
I mean, everyone's figuring out now that, like, I think for a long time, most Americans thought the hospitals were, the big hospital systems were the great guys, the good guys, the saving grace. Unfortunately, it's just not true, people. And we need to divest you of that notion, but hospital costs have outpaced pretty much every other segment of our economy. Like it's more, the growth curve on hospitals is even steeper than It is for college, and we're paying two for college right now. And Caren is well, one at least.
When
It's ugly. So you know the hospital costs must have something going on, and we also know that pharmaceuticals are absolutely astounding, and then the cost that we're paying for insurance is astounding. And believe it or not, it's all tied together. And I like to tell people there's two sets of middlemen that most people in America weren't even aware of. Does one of you want to give the acronyms and what they stand for?
Oh, the PBMs, the
Yep.
pharmacy benefit managers of no benefit, and the GPOs.
Well, there are some small PBMs that actually are good and do good,
And the
right?
ones that truly do what they set out to do.
Yeah.
And then there's the group purchasing organizations and GPOs, and they're the providers of supplies and medications to hospitals. The PBMs supply the pharmacies.
Yes. The PBMs make the deals between the insurance companies, the pharmaceutical companies, and they decide which drugs go on your insurance formulary. So that's that list of drugs that your insurance company approves, the things that they will pay for, and things they will not pay for. They make these deals with insurance companies to put a certain amount of drugs on there, and then they get these fancy rebates depending on how many of those drugs they add on there. All kinds of really interesting schemes that they do that's very legal. But they're not the ones making the drug, and they're not the ones doing the research or anything. They are just deal makers.
Perfect. It's kind of like,
Yep.
in fact, I'd love to run through. So one of the astounding things that I've discovered, and I'll give you a couple examples. Everyone knows in America that the insurance companies must be a part and part of what's wrong and broken. And everyone talks about how much money these insurance companies are making. But let me give you some facts that will absolutely astound you. So if you look at CVS Health is functionally an insurance company, right? Because they bought Aetna. A few years back, they had $62 billion sitting around, and they decided we're going to snatch up Aetna. CVS bought an insurance company and now owns it. So functionally, they are an insurance company with a lot of other arms. Guess what percentage? I know you both know this, but I guess I want the audience to think in their minds just for a second. What percentage of what CVS earns do you think the PBM earns for them? So just think, because you're thinking CVS, all those little stores, you're thinking they own an insurance company. Astoundingly, CVS's PBM, called Caremark, 60% of its revenues come from the PBM. Like, holy crap, right? Who's saying holy crap? I'm saying holy crap. Are you guys saying holy crap?
Yes.
All right. So get this. Cigna purchased Express Scripts, another PBM. There's three big PBMs: Optum, Express Scripts, and CVS Caremark. Those are the biggies, right? Cigna purchased Express Scripts several years back, just at the same time that CVS was buying Aetna. Like now all these little mergers are happening, these evil deals. And when they purchased Express Scripts, Cigna, the insurance company, its revenues tripled. Tripled. Check that, people. Tripled.
Don't you see Miss Pac-Man in there? Eating everything.
Yep.
Yeah. Pocket, whether it's your robe pocket or your jeans pocket or your pocketbook pocket. Totally.
But, no, not my pocket. My pocket has a hole in it for this mess.
Money's cash cows. So
Yep.
how do these PBMs make their money? How about we count the ways?
Yeah.
So and I want to leave the most shocking for the last, but can I go through the 5 or 6 big ways that they make the money?
Yes, please. Let's do it.
So there's something called DIR fees, direct and indirect remuneration fees. So if you can imagine, these pharmacy benefit managers, in addition to making up the formularies, they get to collect a little snippet from each prescription in America. Think about how much money that is. And these fees are completely hidden. No one knows what they are. So you talk about transparency. No transparency.
Everything's secret.
Secret.
Yep.
Is secret ever good? If you're hiding something, you must have
You
something.
must not want people to know. You must be getting something out of it.
Be up to no good.
Yeah.
Exactly. So in addition, so that's way number one, these DIR fees. These PBMs, they also have, a couple jobs. They don't just do this for the insurance companies, but they administrate the Medicaid prescription benefits.
Yes.
So our government is silly enough to hire these middlemen to administrate the Medicaid prescription benefits.
Right.
And
I should have said third party payers, but yep.
True. So
that is key. That is really important, this part.
That's right. Because when someone else is paying, we've lost sight of, how much things cost. That's how we got to this trouble, right? Yeah. And that was, by the way, a great intro that you gave, Caren, at the beginning. But so these PBMs, because the amount that they are taking to the money that comes from Medicaid to pay the pharmacies for the prescription drug benefits, they don't have to make that visible either. So sometimes they keep a portion of it. Notice I did not say small portion.
Yeah.
This is called the spread. So in other words, we'll just help ourselves to this like buffet spread here of money. And in Ohio, in 1 year alone, it was found that they were keeping $224 million in your state, Dr. Johnson.
Yep.
$124 million. Let's just help ourselves to this spread, this smorgasbord of money. That's on top of the DR fees.
And that one finding actually set off our attorney general to actually our current governor was the attorney general at the time, who started looking into this and really taking a deep dive into these PBMs at that time. And since then, Ohio's been rocking it. So we've been peeling back the layers and making this stuff a little bit more transparent. So
Arkansas, other states Pennsylvania ain't rocking it. Our attorney general, he's busy suing everyone that's making money off the opioid.
You're cutting in and out a little bit. It's your bad Wi-Fi.
No, or maybe I'm exposing someone. Pennsylvania, Josh Shapiro, he's done a great job of suing a lot of people making money off of the opioid crisis. But if you think about it, every opioid prescription, there's PBM benefits. He's sued everyone who's making money except the PBMs. So I'm asking publicly, Josh Shapiro, why aren't you suing the PBMs? I'd like to know. Yep. All right. Door number 3. How are these guys making money? All right. Do you guys know any independent pharmacists?
Yeah.
Me too. Yep. You guys.
I use my own. Yeah. I use our local pharmacy.
That's
They're
right.
Struggling. They are struggling.
There's 20,000 small pharmacies in America. There used to be about 23,000. So we've lost 3,000 small businesses in America in about the last 10 years. And these small pharmacies are struggling because they have no idea, these little small guys, how much they're going to get paid by these PBMs. But mind you, if you are CVS, Caremark, the PBM, and you're paying the pharmacy, I mean, I guess you're allowed because it's all hidden, right? You're allowed to pay CVS pharmacies more, and you can pay the little pharmacies less. Astounding, but no one knows because it's hidden. More hiding. And so, what do you think that they do with these small pharmacies when they get, they're in trouble financially? These little pharmacies. What do you think CVS comes and does to the small pharmacies?
Miss Pac-Man?
And Miss Pac-Man is back. She's eating up the.
They come along and they offer to buy them.
Yep, exactly.
So they
can bail you out.
Yep, offer to buy them. We're going to bail you out. Now there's another CVS with that little robotic looking heart on the corner next to you, and that little CVS is able to collect the DIR fees. They're able to take money off of the Medicaid spread, and then they're able to pay more places less because they've got more. Dr. Gallaher, I'd really love you to talk about a great example of how CVS employs.
Hang on, I'm going to just show this comment here. Kennedy says that she gets her meds from her DPC doctor. Right.
Oh, beautiful.
So I'm sure that saves a ton. So you're bypassing the middleman that way.
It is. It
Yep.
is.
And so that is one way that you guys can save on prescription meds. We talked about direct primary care last week. And if you are in a state where your doctor can actually buy medications at the wholesale price, they can dispense it directly from their office and get you a much cheaper price. So thanks for chiming in there, Kennedy. One of my favorite followers on Twitter.
Me too.
Beautiful.
So Marion was talking about, CVS is not looking like a very good guy anymore. They're vertically integrated and with this huge conflict of interest where you have the pharmacy and the insurer and the PBM all linked together. So now assume that you have insurance that's telling you where you have to go get your care. And oh, by the way, we own CVS, and we're making CVS into a health hub, and we're going to have these minute clinics, and that's where you're going to go get your care. And our PBMs make sure that their deals are at the top of the formulary, and those are the drugs that are going to be prescribed the most because everybody's getting kickbacks from that. So now comes along a new sweeping wave of legislation allowing non-physicians to practice medicine.
Yep.
And this is what's happening in 24, 25 states, DC, the VA, where nurse practitioners and now PAs who used to work really well on teams led by physicians in a very cohesive manner are now being able, with no further education, and with nurses, I love nurses and I love nurses on teams, and RNs are so valuable to us, and nurse practitioners who work on teams are so valuable. But now they're having people who've not had a single day in medical school being put into medical clinics where your insurer says you have to go to this person at this pharmacy, and that person is likely to prescribe you a drug that's on their formulary. So it's just a big circle of everybody scratching everybody's back and making money off of the patient, and they just keep squeezing our wallets because we're all
right.
patients,
But Dr. Gallaher, it's cheaper to actually train and produce nurse practitioners and PAs. I mean, doctors have to go to school for a longer period of time too, so we can churn out nurses a lot faster. Nurses, they go straight from high school into nursing school, and then they can get their doctorate of nursing and do the same thing physicians can do, right?
Wrong. Except it's not the same thing, because nursing is not medicine. There's different tenets, there's different philosophies, there's different mechanisms of education, there's different licensing, there's different testing. And so what's happening is this big veil of opacity, lack of transparency, is being pulled down across everybody's eyes. And who's paying for it all? It's the PBMs. If you look at our legislators who are passing these laws, they all are being funded by the PBMs. They all look at their donors. It's a litany of CVS and Caremark and Optum and all the players who will benefit by having someone who's licensed to distribute their medications. So it's just another layer of feeding into this huge amount of if I say corruption, it sounds really horrible, but I mean, the system is corrupted.
It is.
It's not.
Yes, that is the word for it. It is all corrupt. It's all tied together.
And it's not just, it used to be there's a physician and a patient, and the patient went to the physician for medical care, and the physician called the pharmacist to help them get medication that they needed to prescribe for the patient. And we were all working for the patient. And then came the hospitals, and they're like, oh, let us help you. You can bring your patients to our hospitals, but we'll help you. And everything has changed. It's like, the upside down. It's nothing is right. It's everybody is working to squeeze the patient for money. And physicians are owned by corporations now. They're owned by hospitals. They're owned by PE firms. Even the nurse practitioners who are working in, CVS, they're owned, and they're being told what to do by corporations. There's not the autonomy to be able to care for people the way that you feel and you've been trained to care for them.
And that is an important piece that I want to bring up too, because a lot of patient complaints are directed towards the doctors and the nurses for not being able to see them fast enough, not being able to spend as much time with them, going into the office and you're behind schedule and you have to wait for your doctor for 30 minutes or more, and uh, because the insurance company won't reimburse enough, or Medicaid won't reimburse, Medicare won't be reimbursed enough, but the administrators in the hospital want the doctor to see patients every 15 minutes. So a brand new patient, they want you to see them in 15 minutes. So you can't talk about the thing that's bothering you. If it's a regular checkup visit, you'll have to come back and do that again at another visit. So they want to just cram as many as you can. And so who is the face that you guys are going to that our patients are seeing? The face the patients are seeing are the doctors and the nurses. And so we're just as frustrated as you are with this process. And as we keep alluding to, it was not like this when we started our training and started our education. So this is really key how it all ties in together. So what can we do? This podcast is about solutions, and Free to Care itself is about solutions. What can we do to help not only our patients, but also the physicians and the nurses who are watching and engaged, and even the nurse practitioners who don't like the way this is going and don't want to be taking care of patients without physician team collaboration or supervision, and understand that their scope should be limited. What can we do to actually make access better for the population, lower the cost of care, lower the cost of prescription drugs? How can we advocate?
Well, how about we start in the middle? I mean, everyone's looking at like cutting out the physician role. Like, Caren, you just mentioned that, places are, there's CVS looking at not even having physicians involved. Well, let's start and take a look in the middle. We talked about 4 of the ways that PBMs make money. How about we use some transparency and expose these ways? Why aren't the DIR fees, these just little fees that they collect off of each prescription, why aren't they transparent? Why isn't the spread transparent for everybody? Why aren't the little guy pharmacies, how much they're getting, why isn't it transparent so that we can discover that there's it's almost an internal kickback if you're paying your own pharmacy that you own. The PBM owns the pharmacy and the insurance company, and you're paying them and paying the little guy pharmacy out of business. That should actually be pretty transparent too. And we talked about this integration.
Mm-hmm. And doctors can't even own hospitals because the American Affordable Care Act people decided that it was too much of a conflict of interest for us to own and run hospitals, even though there's evidence that the quality of care is improved, cost effectiveness and efficiency is improved when doctors are running in charge of things and making a part of the decisions that are purchasing equipment, looking at the actual outcomes and seeing what medications, what devices, what procedures actually help people, rather than looking at algorithms and the risk benefit that is in favor of the hospital and not necessarily the patient. So,
and isn't it ironic that there are Stark laws? There's laws that prevent physicians from referring to ourselves, meaning like we couldn't buy a lab and then send all of our patients to that lab and profit from that lab and profit from seeing the patient. Yet these corporations that are supposed to be persons, they do it all day, every day. They vertically integrate and they refer to self and they make money coming and going, kickbacks from all ends. And that's what drives our care up. So you're talking about what can we do to bring solutions? And the first thing is to basically start to understand the process. what's going on? How can we do things differently? What can we do to get people to listen to us? Talk to your friends, show them the podcast, write a letter, call your
Yes, please.
congressman. It's very easy to say, look, I heard about these PBMs and Ohio, they were able to audit their PBM and it's going to cost their state a whole lot less. I want to pay less taxes too. Can't you audit my PBM in my state? There's a lot of things that we can do that are very simple, but it takes it back to the individual. If we want individual health care, if we want individual specific transparent care, we're going to have to get an army of patients. We're all patients, and we need to join together to demand that we have this transparency.
Yeah, absolutely. I mean, we need y'all. We do. We need y'all, and this is why we're bringing this topic in this show to you. That is the point. I want you to be inspired and fired up. I want you to get mad and and realize how much this stuff costs and how these people are controlling it, and we can take them out little bit by little bit, and we can do it state by state. And so call up your state attorney general office, call up your state legislator and your state senator and tell them you want, PBMs investigated. The federal trade.
You can just do it on Twitter. You can get a huge following. You can. You get a lot of people together and they're all asking for the same thing. They're going to listen to us. They're going to start listening if there's a lot of people saying the same thing. And a lot of people can be 20 people in a day. That's not a lot of people. But
exactly. Spread the word. Yep. Tag your legislator. Most of them they're on social media anyway. So you can go to their Facebook page or Twitter page and tag them and say, hey, why don't you look into this PBM thing? I mean, even if you don't know the language, things that we're telling you, just use the word PBM. They know what it is. But yeah, we need you guys. We need an army of you advocating for yourselves as well, because we don't, we can make much of a wave, a little bit of trickle as we can with the few of us who are actually out there voicing it and doing the legwork and meeting with the legislators. But when they hear from their constituents, they have to listen and do what you tell them to do or risk not getting voted back in.
Well, sure. And actually, one thing I'll say is there is a bill in the House right now, H.R. 19, the drug bill, and that drug pricing bill, only major drug pricing bill in Congress that is asking for supply transparency and asking for some transparency around the PBMs. Ask for that bill. And actually, one other thing you can do for transparency is transparency in the quality of your own care. We've mentioned that I think patients are often confused. Who's treating me? What's their level of training? Ask if you're going in to see your for an office visit or you're in a hospital. Ask what the level of training of the person that you're seeing.
Well, and that's a really good point, especially since a lot of these corporate-owned hospitals are starting to remove their physicians. There's a glut of ER physicians, not because we don't need ER physicians, but because they're not using ER physicians in the emergency rooms anymore. They're using cheaper, easier to replace, more malleable options that can bill at a maximal level. And so you need to know before you go. You need to call your emergency room and say, are there, board certified emergency room physicians working here? Who's staffing this emergency room? Because you may wind up in an emergency and find that you don't have a physician there to take care of you in the ER and the OR for anesthesia or in the ICU even. So it's important for you to know, this goes along with all the transparency. And, the hospitals, 80% are breaking the law without repercussion. They're not transparently showing their prices.
Amen.
So what makes you think that they're going to do anything else regarding transparency? We're going to have to demand it as patients.
Hey, can we bring up another connect between these middlemen and the hospitals to bring it on?
Yes.
All right. So, we talked in the podcast about the ways that PBMs make money, the DIR fees. We talked about spread, helping themselves to Medicaid money. We talked about them boxing out by pharmacies. We talked about the vertical integration, conflicts of interest. We could talk about specialty pharmacies, but that could be another whole topic. Let's leave that one.
Oh yeah. Yeah.
Yeah, but here's my granddaddy. Here's the grand plan. Like, so if these guys already do not sound like a cartel, like some type of corrupt beast, like some kind of mafia, get this. These pharmacy benefit managers are one of 2 industries in the United States that are allowed to accept kickbacks and don't get sent to jail for it, don't get prosecuted for it. Astounding. Did you hear that? Kickbacks? Wowza. How do you think they got the right to these kickbacks? Who gave it?
Let's see.
Who gave it to him?
Congress.
Yes. Yes.
I feel like tires. Ooh. I wish
Right?
light, but the sun's going down out here.
I know. I wish I could give out prizes for, people who get the answer or something.
Yeah. Should ask. All right.
And one of the answers too, I see Deb Kennedy on here talking about how she got involved in Twitter and educated herself and wound up getting a direct care physician and wound up being able to pay less for great medical care and less for prescriptions. And you had Kim Corba on here, who's a great example of what direct care doctors can do, and just investigate in your area and see where there's a direct care doctor. It may be the right answer for you. No, we have great insurance, whatever that means anymore, but our deductible's huge, and we use a direct care physician because fortunately we're blessed with good health in our family, but we spend a whole lot less going to a direct care physician and getting our medications through him and getting our tests and our labs through him than we would if we went and used our insurance and paid that huge deductible. My husband needed an MRI of his head, which fortunately only showed marbles. No, it was fine. But in a hospital with insurance, it would have cost $4,000 out of pocket because of that high deductible. He paid $400 cash for an MRI, same MRI, read by a radiologist. It makes a big difference. There's a lot in this transparency that is so critical for us to make good decisions about what kind of care we want.
Sure.
Right. So can we just go backwards a little bit, Marion? What is the what happened? What did Congress do to allow these PBMs to have these, to get these, like, do this money laundering scheme? Basically, I call them the medical mafia. But what did they do to allow this? And I mean, what was the original intent?
Well, let's dial back a little bit. I guess I can't see I don't figure out that there's any good intent here at all. I think the intent was on the side of the profiteers. But even before the PBMs got their right to legalize kickbacks, remember at the beginning of this podcast early on, we talked about there were 2 groups that were hidden. The other group hidden is the GPOs, the group purchasing organizations. Group purchasing organizations were granted by Congress in 1987 the right to legalize kickbacks. They got them first. These are the people that handle contracts for all of the supplies in hospitals and nursing homes. Now think about that. All of the supplies in hospitals and nursing homes. In some hospitals, the hospital overhead, 4% of it is the supplies. That's huge. Remember how we talked about how expensive and how steep the hospital curve was? You think if 40% of the overhead is the supplies, you think it has anything to do with the cost of the supplies? Yes. Just like the PBMs make the formularies and have the right to get paid by the manufacturers that are supplying the drugs that are going on the formularies, the group purchasing organizations are getting paid by all of the suppliers. They're able to get paid, which is a kickback, and they're deciding which supplies are getting into the hospitals. Now there's
and when in the beginning of the pandemic, and when we couldn't get masks and we were rationing masks, and we had these public health officials telling us not to wear cloth masks, surgical masks, save those for the doctors and the nurses in the hospital. What does that have anything to do with these group purchasing organizations, Dr. Moss?
Absolutely, because the masks, the gloves, the gowns, the N95s, all of that gets into a hospital via a group purchasing organization. They're the ones writing the contracts. And so over time, what has happened is because there's only, it switches, and the group purchasing organizations themselves are integrating. So they're buying up each other. And now there had been 4 large ones. Now we're kind of moving towards where there's 2 giant group purchasing organizations. But you haven't heard of the names of most of the GPOs, but I'll name them for you. Vizient, Premier, Health, Intolare. And now they're getting vertically integrated into the hospitals. So, you asked about the masks and the gowns. This applies to medications, but when you're making contracts and deciding which brand product is getting into the hospital, what has happened over time is the really rich companies that make these products just pay more, get the right for sole source, and they're the only ones making. And so then now if you need a lot of gowns or masks or gloves all at once, you can't up your supply, because if there's only one company making most everything, it's just too hard to get it into the market. So yeah, it did have what to do with the fact that, physicians around the country, some of them were being.
You just cut out, Marion.
So this great corporatization of healthcare, it is actually limiting competition. So we have this great sprawl of these vertically integrated and mega hospital systems. They're actually diminishing our ability to have any competition or a free market that drives prices down. Now we have secret contracts and kickbacks.
Well, I mean, there's a free market. We can't say there's not a free market. It's just not a fair, free and fair market.
It's not a true free market. Because it is limited. I mean, you can say that the direct care models allow a free market to compete, but it's not.
But if you have certificate of need laws in each state, then you have the doctors have to demonstrate that there's a need in that area before that they can even open their practice. So so nobody's saying, hey, no, you can't open a practice or have a business, but you have to pick your business location in a place that we think you're needed. That is what makes it unfair. And so they can still say it's a free market, but they can't say that it's a free and fair market. So that is key. And so this is a local problem. So you can also tell your state legislators, your governor, to get rid of certificate of need laws as well. So I don't know about any specific legislation right now that is addressing that. Do either of you?
In Tennessee, there was I guess the year before COVID, the session before COVID, so 115th congressional session, there was a big investigative process about removing our CON. Not all states have CON any longer, but the way this works is if I wanted to open a surgery center, I would have to apply, and the hospital systems could negate my application. They could say, no, we don't need another hospital. We don't need another ambulatory center. So we're not, the legislators would then not allow you to proceed with that. So they could squash any effort an individual wanted to start any kind of outpatient ER or outpatient surgery center or urgent care. They could squash those. And it was very interesting to sit in those legislative sessions of investigation because it became apparent, our economy in Tennessee and in most states is mostly driven by this big health cartel, the healthcare industry. And so when legislators start messing with them, they worry about the financial sanctity of their state as well. It was very interesting to watch them pause because if you continue status quo, you don't rock the boat. If you start changing things up, you are upsetting a very big sleeping giant. It's interesting. So I don't know how it's proceeding in other states, but it would behoove us all to, again, push to repeal the CON, certificate of need laws in our states.
Right. Absolutely. We don't have them in Pennsylvania. It's a little like Rodney Dangerfield in Back to School. Remember when he and Thornton is saying this is how you run a business, and Rodney Dangerfield says, no, you got to grease the palm. That's what got to happen. Hey, one of the things I think would be smart is to kind of tie it a little bit together between, you know, Caren, you talked about the training grounds of the non-physician providers, and we talked about hospitals and PBMs and so on and so forth, and who's owning who. You know, something that's really fascinating to me is HCA, and I believe that started in your state, right, Caren?
Yes, it did.
Yeah, they own 9,000 hospitals around the country, 9,000 institutions. Maybe they're not all hospitals. Astounding, right?
Yes.
Well, HCA, they're busy, aren't they? Like now training nurse practitioners in
They're training practitioners. True.
Yeah. So they're
a corporation now. It's not even just universities educating health professionals. You now have corporations that are doing it too, and corporations that have an interest in doing that.
Yeah, and then you have big policy think tanks that are behind this. The Robert Wood Johnson Foundation is one of those that believes that nurse practitioners should be the next, are the next primary care doctors, basically, and that they can fill the needs, but it's all a bunch of hogwash because that's not even what they're doing with their certificates.
And let's be really clear. This is a public safety issue.
It is, absolutely.
This is not a turf war. This is not, we're worried about, we're not going to have a job. Although some people are worried about not having a job. This is about worrying that when we're sick, because like I keep saying, we are all patients.
We are all patients.
When we are sick and go to the hospital expecting expert medical care at a hospital and find that there are no experts in that hospital, what do? When we get referred by our expert pediatrician to a tertiary care center because our child has some rare disorder that needs an expert, yet you have a wall of non-physicians that you have to see first to get to the expert, even though you've already seen a board certified pediatrician and they needed expert care to assist them, you're getting somebody who's not even been to medical school. It's bad. It just adds a layer of billing. It's a billing widget.
Yes, it is.
Adding just more layers of billing. It's not cheaper. It's not safer. They don't go rural. All these corporate entities that we've named, the hospitals, the PBMs, the GPOs, the insurers, the PE firms that are buying up physician organizations and practices, the societies that we all pay dues to.
Oh gosh, yeah. It's all tied in together.
The lobbyists and legislators, it's all part of this big health cartel that's making money by squeezing our wallets.
But if we could get back to HCA for just one moment.
Yeah, go back to that. We got I'll give you like a minute on that.
Yeah.
And then we'll start wrapping up because,
So you take a look at that HCA and they are part owner of, I believe it's Health Trust, one of the big CEOs. So let that sink for you a minute. The big, just like CVS Caremark owns Aetna, owns the PBMs and all the rest. HCA, who owns 9,000 hospitals, is part owner of GPO. I'll tell you something astounding. Remember how hospitals were all saying they were all losing money in the pandemic? If you look at the CEO of HCA, bottom line of HCA itself, but the CEO, 2020, I believe his salary went up something like 300%. I'll look at the numbers and make sure, but it was astounding. Now, they're making money off of all the supplies because they own GPO. So all of the testing, all the COVID testing, all of the supplies that were taking care of all the sick patients in all HCA hospitals, they're making money because they own the GPO. And, we talked about what are they doing with that money? They're running training programs and now they're getting different widgets. I actually feel very sorry for the modern nurse practitioners because I think what's going to happen is they're going to become major pawns in a system that's just going to disintegrate before us.
Right. And a lot of them don't even understand what's happening. They're actually being told that they could easily replace physicians and do exactly what physicians do. They are being lied to also. So they don't necessarily know what they're getting into. And so that's a huge part of this. So So just kind of sum it up. We do need you to, one, keep watching, keep listening, check out freetocare.org, learn what the real issues are, learn, peel back the layers, and to learn what's really causing all of your the costs in healthcare, your insurance, rates and premiums, deductibles, your medication costs, your hospital fees, your surgery fees, all of these things. What is making it cost you so much? We talked about, several of the big reasons, but tonight we really kind of focused on the PBMs, or the pharmacy benefit managers, and the GPOs, the group purchasing organizations, and all the deals and the things that they're doing that to contribute to this huge problem. But again, we are a solution-based podcast. We gave you some solutions. Please, HR 19, right, Marion? Is it 19? Because I don't want to get my numbers mixed up. Yeah, so tell your congressman to pass that. Go to patientrightsadvocacy.org and get that letter off to HHS to let them know that that you want your hospitals to post their prices transparent. And then the third thing you can do is demand a doctor, demand a physician, go see a direct primary care physician, for competition, get your drugs cheaper, use an independent pharmacy, but demand a physician when you actually go to a big hospital or health system. Don't accept a substitute that has less training, less experience, and basically does exactly what the hospital administrators want them to do. Ladies, thank you so much for joining me. I love chatting with you. We could do this for hours and hours at a time into the night. Please just give a minute or so, something positive, something great about life this week, something you're grateful for, something that made you smile, something that just blessed your soul.
I'll go. I am grateful for the opportunity to meet people like you guys. Really changed my whole life in the fact that I can understand now that a single voice can make a difference, that we can lobby for ourselves, so we don't need lobbyists. We don't need people who are paid to go talk to politicians. We can pick up a phone, we can write an email, we can tweet. And Marion, you really bring that out in people so well.
Yes.
That you inspire us all to step out of our comfort zone and to do the right thing, to demand truth and transparency, and just do what's right for our patients, for our family, for the people we love. And that always is very inspirational to talk with you guys. It really makes my day.
Oh,
that's awesome.
Oh gosh, I'm grateful. I'm grateful for the freedom that I can speak out. I mean, that's our first, right? I'm grateful for that. I'm grateful to be surrounded by, and I always have been. I had wonderful parents. They're both gone from this earth. They inspired me to advocate. They were outspoken people themselves in their own community. And the fact that my mother got bad care, but really pushed me into it. So I'm grateful in a way that I had that experience, because it's allowed me to meet so many wonderful people. I have a wonderful family right now, a very supportive husband, very supportive children, many supportive friends like you guys all around, and a supportive community. And one of the things that I'm happy that's like a positive, I'm starting to see, we talk about all these like big corporate middlemen. I'm starting to see small business people get together and start to find solutions outside of advocacy in their state and national legislatures. They're starting to build it themselves. And you know what? Build it, they're going to come, because the public is tired, and I can't blame them for being tired. They're paying more, they're getting less. They need an alternative. Competition, bring it, baby.
That's right. That's right. Oh my gosh, you both Again, you just demonstrated why you're my inspiration and a joy to have in my life. Thank you again for giving me an hour of your time on a Friday night at the end of crazy busy weeks, because I know what you two do during the week and everything that's going on in your lives. So, I love you from the bottom of my heart. And I just want to thank everybody else for joining in tonight and giving me some of your time to learn about this and hopefully inspire you. Enjoy your Juneteenth freedom celebration, however you decide to do it this weekend. I'm also going to be celebrating my 22nd wedding anniversary with my husband. And I'm excited to have some time to spend with him and my little bitty family here. So thank y'all and have a good night. Remember, healthcare is personal. It is not partisan. These are nonpartisan solutions to something that is for the individual. Thank you.
Have a good night.